Hello, everyone. My name is Dr. Gloria, and I'm a clinical psychologist and assistant professor at Vanderbilt University Medical Center in the Department of Anesthesiology. Today, I'll be talking about a study looking at the prevalence and clinical characteristics of children with autism and chronic pain in a multidisciplinary pediatric pain outpatient setting for this year's Autism CARES Research Day. Children with autism have differences in sensory processing that include both higher and lower sensitivity to sensory inputs compared to their non-autistic peers. There's growing awareness of higher rates of chronic pain in this population, but the prevalence and experience of pediatric pain in autism remains poorly understood. To address this gap, we reviewed electronic medical records of patients receiving care at our interdisciplinary pediatric pain clinic here at Vanderbilt Children's Hospital. Our database includes demographic information and clinical characterization based on standardized measures, including the Functional Disability Inventory, which is an assessment of how much pain is interfering with daily activities, the 4-item Patient Health Questionnaire, which is a screener for anxiety and depression, the Fear of Pain Questionnaire, which assesses the extent to which fear of pain is leading to activity avoidance, and finally, the Children's Somatization Symptom Inventory, which assesses somatic symptoms in many areas of the body. Autism diagnosis was assessed based on whether or not the individual already had a prior community-based diagnosis of autism or a new autism diagnosis that was determined by a pain psychologist with clinical reliability on gold standard assessment tools. Importantly, we really prioritized a biopsychosocial approach, leveraging insights from our pain psychology, pain medicine, physical therapy, and occupational therapist colleagues. The current analyzed data set includes 51 patients who attended our clinic. The mean age is 14 years old, and the sample is 73% female. This donut chart shows that 8% of children, or 4 of the 51, already came to our clinic with a prior diagnosis of autism, and then an additional 17% were identified to meet criteria, yielding 25% of our clinical sample with a diagnosis of autism. 54% of autistic children presented with widespread pain, indicating that they were experiencing pain in many different parts of their body that often shifted or changed in intensity and frequency from day to day. 46% of our children were assigned female at birth, which is notable in that it is much higher than the 4-to-1 male to female ratio that is often cited in the autism literature. Autistic and non-autistic children did not differ in terms of standardized symptom measures, but qualitative results did suggest that autistic patients may have difficulty or differences in describing pain sensations, describing pain-related emotions and internal body experiences, and identifying pain-related cognitions or beliefs. To conclude, there's a significant overrepresentation of autistic children in an outpatient pediatric pain clinic, and the pain complaints of autistic patients were generally nonspecific and widespread, suggestive of nociplastic pain, or in other words, that their nervous systems are more sensitized and therefore amplifying pain signals. Measures for assessing chronic pain in autistic children, especially in those who are minimally verbal, are needed to characterize differences in the brain and body-based pathways that might be affecting the experience of pain in autistic children. In the future, we want to encourage continued interdisciplinary collaboration with occupational and physical therapy colleagues, along with our physician colleagues, to assess and treat chronic pain in children with autism. We also acknowledge that interventions prioritizing somatic awareness and sensory integration, which is one's ability to take in, organize, and then respond to sensory information, may be particularly helpful before more insight-based strategies like cognitive behavioral therapy are used. This work engages community stakeholders because the data itself includes self-report of autistic children and their families and active discussions with our interdisciplinary clinical team. Vanderbilt also has a wide catchment area across the state of Tennessee and in neighboring states in the Southeast. As far as next steps, we plan to maintain our patient database so that we can continue to monitor the prevalence and experience of pain in autistic children. We will also assess self-reported and use objective measures of pain processing in autistic children to further understand pain in this population, and then use these insights to adapt or develop new evidence-based interventions. I'm interested in feedback to hear how others have observed, experienced, or assessed chronic pain in autistic children. And as I'm preparing for a larger study, I would be interested in feedback on how to also include assessment tools for children who are minimally verbal. Thank you so much for your time. Please don't hesitate to reach out at gloria.hahn@vumc.org or follow me on science Twitter at Gloria T. Hahn. Thank you so much.